Good afternoon. Can everyone hear me, or do I need to use this? Yes, we can. Okay. First off, I'd like to welcome everyone to what is now our third Board of Associates meeting. For those that have been here before, you're familiar with our Board of Associates is a community group that acts as advocates on behalf of our network. And in turn, we share information about the hospital, about the healthcare network, to you as a way to clarify sometimes information that is disseminated throughout the community. Sometimes you'll hear rumors and you'll hear talk. What we are trying to do is provide you that information as a conduit so that you can, in some cases, dispel rumors. In other cases, share good information about our network. And that's really what this is about, is we want to share that and make you a community part of our network. There's a lot going on here, and you're going to hear from Elizabeth Wise, who is our president, toward the end of the meeting. She's going to give you an overview of the health of our network here in the Pocono region. She'll talk about some things you may or may not have read in the paper. But first, I'd like to bring up Erin Ludwig, who is with our communications department. She's going to tell you, actually share with you some good news. For those that did not know, Lehigh Valley Hospital Pocono has been nominated in many categories for Best in Business. I will turn it over to Erin.
Good morning. Hi. Yeah, I just wanted to take a moment. So the Pocono Record has their Reader's Choice program going right now, and it's something that we kind of look at as a network, but specific to Pocono. First of all, congratulations, you got nominated in 20 categories. So I had to bring my list. And I think that's nice because, you know, we were nominated for Best Hospital. We were nominated for the cancer care that's provided here at the Dale and Francis Hughes Cancer Center, but also in categories like Best Company Culture, Best Overall Leadership, Best Company to Work For. So I thought it was really nice recognition that the community, you know, there was a first round of nominating, and now these are the finalists who are going into the vote. So, you know, a moment to kind of have advocacy in action. So if you feel so inclined to jump on and vote for Lehigh Valley Hospital, Pocono, and LVHN services, that would be great. Thank you.
You're very welcome. Thank you, Erin. Now I'm going to bring up, we have a fantastic program. I have been fortunate enough to see this presentation once before, and it really speaks to how technology and advancements in technology are changing medicine and the way we treat our patients. So you'll see here, Imagine Major Surgery with Minor Recovery. We're going to talk about robotics. And I will, at this time, turn the presentation over to Dr. Bacala. Dr. Bacala and Dr. Kim, you will see on the back of your agenda, when you get time, you can read a little about their background. But at this time, I bring up Dr. Bacala. Thank you very much.
Thank you. Thanks, Dave and Erin. Appreciate you guys allowing us to come up and talk a little bit. I'm going to hold this, so let me know if it's not working well or if you're having trouble hearing me. You having trouble hearing me well?
So you want this one?
Yeah, let me use that one instead. Maybe that'll work better. Okay, is that better? Can you guys hear me better? Okay, good. So thank you for having us up here. I tend to talk loud anyway, so if I may not need this. So if I'm talking too loud, let me know too. We enjoy coming up and speaking a little bit because there is so many great things happening at Lehigh Valley, and specifically in our Department of Surgery and OBGYN, and with our cancer work that we do. We have a lot of new opportunities and a lot of new ways that we're approaching healthcare. And I think that's really the most important part about what we're going to talk about today. We talk a little bit about major surgery, minor recovery. And yes, the idea is we are doing some major things in surgery and changing the way that we're doing it by improving the outcomes for patients and making their recovery better. But we're also looking towards changing the way we deliver healthcare. Clearly, we all know that we have to make healthcare better in the sense that we have to make it less expensive, And we have to improve outcomes while still keeping quality high. So we need to bend that cost curve, but still keeping our quality high. And robotics is one way that we do that. So, as a division chief in urology, we've really taken on robotics a lot in urology, and a lot of what we do now for our major cases is done with robotics. And in fact, some of the things that we're going to be doing with our minor cases, we're going to start using robotics for too. And people ask, why do you do that, right? And that's really the question. What's the why behind why we do this stuff? It's not so much that it's neat and cool. It is. There's no question. It is neat. It is cool. It's neat to see these things. But it's also because we're there to give better outcomes to patients. And we found that we can do that with robotics, while at the same time, even though robotics can be expensive, because of the downstream effect of what we do by getting patients out of the hospital faster, decreasing the amount of readmission rates, improving the overall care, we're actually able to bend that cost curve, even though the upfront cost might be a little bit more expensive. So that's a little bit about what we're going to do. And that's, wearing my other hat as the Institute for Surgical Excellence. With that, our institute really is geared towards looking at those types of things. So, we started with robotics back in 2004 when I was at the Cleveland Clinic. The very, very early robots that came out, we got access to those and started working with that. As it progressed and some of those key institutions started having it, around 2007, people started really taking on the idea of robotics and people heard about it. And, the question was, you're going to do what? You're going to operate with a robot? Like, how is that actually going to work? The normal operations of making an incision, cutting, doing this type of work, that was the mainstay of how things were done. And, very similar to how flight first took off with the Wright brothers or with Charles Lindbergh in 1927 when he flew from New York to Paris. These were all, very early things that came out for flight, and this was the same type of thing. We had a mainstay of surgery. We knew how surgery was going to be done, and we're going to change this somehow. So the Lindbergh cockpit, very rudimentary. Look at the gears and things, and now in 2019, this is what our Boeing 787 cockpit looks like. Totally different. And the same thing has happened with that, with the natural evolution of technology for surgery. We moved from doing open surgery to doing laparoscopy, which is the doctor stands at the bedside with fixed instruments, makes small incisions, and can do major surgery, but is working with a straight instrument that you have to control from outside the bed. As you can imagine, there's only so much movement you can have with that, right? And there's only so many angles you can get and so many types of suturing and things like that you can do with straight instruments. Then we introduced the robot. That changed the game for us completely, because now with the robot, we have wristed instruments, and these are very, very tiny, small instruments that can move at 360 degrees. It can make our operations faster. It can make it better. We can operate in much smaller places. And currently, the way the robot works is you have the robot here, which is, I don't know if this is actually working, but, oh, there it is. It's not showing up well on the screen. But basically what's happening is the patient lies on the bed. We make small incisions. We put the camera in so we can see. And then these small instruments are placed in through these robotic holes that we make. And then we control everything through the console. And right now it's connected by a cable, and that may change in the future. But right now we have to be in the same room. In the future, now with all of the different things we're doing with communications and whatnot, we may be able to actually do this remotely. So when we look into that console I showed you before, it's actually 3 dimensions, right? So that's one of the big differences between laparoscopy, where we stand at the bedside and we look at a TV screen, much like you look at the TV at home, it's all 2 dimensions. When we look inside that robot, it's 3 dimensions. So it's like literally we're standing inside the abdomen operating. So it completely changes the way we have depth perception and all these different types of things. These wristed instruments, which can rotate 360 degrees and are very, very small, change what we can do in the abdomen than what we could have done fixed at our hand with these laparoscopic tools. Again, they're very small. You can see how small these instruments are. They're basically a centimeter, and we can still do all these operations and do very complex ones. So in 2001, there's really no robotics around the whole area. There's a couple, of course, in New York. They kind of had, and we have it listed by procedure, whether we do cardiothoracic, general, GYN, others, urology, listed in different colors. And you can see how really nothing going on around here. And as 2002, we start to pick up and start to see the adoption. And I'm going to kind of flip through this, and you're going to see what happens over time. The adoption of robotics becomes very real, and the number of service lines that are picking it up become huge. So in 2012, there's really robotics all up and down the East Coast. This is all Northeast United States, and you can see really by 2016, it is just everywhere. And the reason it was, again, not because it was just neat and cool to do, it's because we started realizing the value behind doing it, both to the patient and now financially the value as well. The very first robot looked something like that all the way to the left. The wires were all exposed, and we had these instruments which worked, and it did a neat job for us. But the real Da Vinci S, which came out in 2006, really sort of streamlined things. And then as we moved into the SI and now the XI system, basically you can see how it becomes much smaller. We use a lot less room in the OR in order to bring this robot in. And all along, we've had improvements. These are improvements in the vision that we have. We now have much better fiber optics, so we can see. Our clarity is better. 3 dimensions is better. And then the instruments which go into each of these is also better. We're able to use different ones, like instruments that cauterize. We can actually do more things with certain instruments where we can cut, cauterize all at the same time and be a little bit more faster and make the operation better for the patient. The latest and greatest is now the single port system. So there's only 15 of these in the country, and we have one at our Cedar Crest office in Allentown, our Cedar Crest OR in Allentown. And it's approved only for urology. And then as of a few weeks ago, it got approved for ENT. So they did the first ENT case last week, and we've been using it now in urology for the past few months. We're doing robotic prostate surgery like this. We're doing robotic kidney surgery. And again, the idea behind this is to change the way that we're doing the surgery. This is now a single port system. So everything is going through one cannula right here. So it goes in through the area either just above or just below the belly button. The camera goes through there. The instruments go through there. And everything comes through, and basically it telescopes out. So you can see in this little picture over here, you have everything coming through one site, and then it kind of telescopes out and kind of moves around. So you can now manipulate everything through one hole. So that's better cosmesis for the patient. But the other thing it allows us to do is we can now look 360 degrees in the abdomen. Because if you think about it, if you have 4 or 5 instruments in there, you can only turn so far, right? You're going to hit this fulcrum of movement that you can only move so far. If everything is inside of one hole in the abdomen, you can actually look 360 degrees all the way around the abdomen. What that allows you to do is to do much more complex cases. You can do all of it through one incision. You can maneuver all the way around and see much better, and it gives you a lot more flexibility. That alone is great, but the other thing is we should go back to change the operation, right? How can we make things better? So for prostate, we may be able to actually stay outside of the abdomen. So the abdomen is covered by a piece of tissue, okay, called the peritoneum. It's basically an envelope that surrounds all your guts. We can actually stay outside of that peritoneum, which is where the prostate actually lives, and we don't even need to enter into that tissue anymore, that area anymore where the bowel is. A patient, which is typically put on their head and put in Trendelenburg position with their head down and their feet up, no longer needs to do that. We can do it flat. So instead of all the complications that can sometimes occur with respiratory issues during the case and things like this, we can now do it flat. We can stay outside the abdomen. They don't have as much things like ileus, which means that their bowels don't work and things like this after surgery, because there's no more pressure put on the abdominal contents at all anymore. So by changing this, it also allows us to not give the person a drain, because normally we leave a drain in because we're inside their abdomen and we worry about urine leakage and things like this. If we're not in there, we don't need to leave a drain. We can send them home the same day. We went from keeping patients in the hospital for 2 or 3 days to sending them home the next day with the regular robotic surgery. With this, we can send them home the same day. So think about the cost savings that we're going to have now doing these cases like this. Think about the less discomfort we're going to have for the patient, where they don't have a drain in anymore and they don't have to be on their head, and the difference in terms of the quality of the outcomes of their surgery. So again, the idea behind this is not just that it's neat and different, but it's changing the way we operate. improving the outcomes and keeping costs down over time. This is what that single port looks like, this latest technology. We have a camera here, and we have 3 instruments. And the camera can either be underneath, or you can flip it around so the camera's on top. And then the camera itself can flex. It can be 30 degree down, 30 degree up, 0 degrees straight on. So we can look in all these different crazy ways, and at the same time have these instruments which come around and sort of hug the area that we're working. It's a different way of working. It changes things a little bit. We're basically working in an area of a softball, but we can also move the entire softball area anywhere in the body. And we can, with that camera, we can look in different ways, and we can manipulate our instruments to operate in different ways too. So all these flexed arms really increase the robotic function. So when we're sitting at the console and we look inside, this is what we see. We see the 3 instruments now, all flexed and turned. And we control the robot by using the pedals at the bottom. That controls the cautery if we need to cauterize something or burn something. When we cut, we use scissors, and we cut things, and we manipulate the tissue, and we move things around to extract anything that we need to do. All of the other part right here at the console where we put our elbows, that black part right here in the middle, we look down at the screen and we can see things like this, the side view and front view of our instruments, so we know what exactly it is that we're looking at when we're actually in the console. So that's what you see there, where we have the energy setting icons and the settings panel. All that stuff is controlled right at our fingertips, while our feet do all of the controlling of the cautery and so forth. The actual movement of the instruments is done with our fingertips, as you see up here. And that's just past this black bar that you're seeing here. We actually put 2 fingers on each side, and we can open and close the instruments by using our thumb and middle finger, and basically clutch and move all the instruments around while we're in there. These tiny 1 millimeter instruments. Let me see, I just hit something. Sorry. I think I just got out of it. Hang on for a second. Oh.
Easier to use it for free.
I think so. Yes, I'm better at using the robot than I am at presenting these things, I can tell you that. Hang on for a second. Let's move forward. So let me get you through back up to where we were.
I mean, it's pretty amazing, as Dr. McCullough said, there's even something called memory. You think that, we have memory. Well, these instruments that you put in, have a location where after you put the instrument in, let's say you want to change the instrument to a different type of instrument instead of a grasp where you want to use a scissor or something like that, you can literally pull the instrument out, exchange the instrument, and when you put it in, it knows exactly where to stop.
So that increases safety and things like that when you're trying to change things out, right? So you don't have to worry about it going rogue and kind of missing a different area. Thank God, right? So, and then this is just showing the foot pedals here, and as I mentioned before, this is the camera pedal, so it can change the camera within there while you're working. This is the electrocautery ones, and this here will actually move the entire port itself, so you can move it left, right, up, down, and so forth. That softball area that you're working in. So, really the benefits of it, really you control more through narrow spaces with triangulation at the tip. There's also a flexible Da Vinci camera, and you can reach 360 degrees anywhere with that one point and with that one port. And again, the idea is to really change the way that we do the operation and make it better for patients. We currently have done over 15,000 robotic surgeries. We have 50 robotically trained surgeons, and we have 10 robots throughout the network, with, of course, one here at Pocono. These are all the different service lines that we do. So anything ranging from urology to surgical oncology, bariatric surgery, ENT, general surgery, GYN oncology, which we're going to hear a little bit about in a minute with Dr. Kim, reproductive surgery, colorectal surgery. All these are done robotically now, and certain cases are done this way. And what we're finding is more and more and more can be done within each of these different divisions. And what we're finding as well is that we can do it better. We can improve our outcomes, decrease length of stay, keep patients out of the hospital, keep them from returning back, and actually bend the cost curve, which is really amazing. So this is, again, is our current state. with GYN, the estimates is that 1/3 of all surgical cases are going to be done with GYN oncology with robotics. And then in urology, thoracic, and general surgery, this is all being done. They're using the robots in the chest to do these cases. And then what we're finding now is that we can actually start doing additional things. And this isn't in this program, but one of the things that we're doing is using things like robots to actually find lung lesions that are so small that we'd never be able to get to before. We're actually able to go down through a bronchoscope and actually move a camera robotically to get to these areas very, very, very distally inside the lung and biopsy these and get accurate biopsies. Because one of the problems is that we can't get, this is for thoracic surgery, we can't get really good biopsies for these lung lesions that are really far away. And now we're able to use robots to be able to do that. Again, changing the way that we do these things. There's currently multiple FDA-approved systems out there. Clearly, Intuitive Surgical is sort of leading the way, and this is what we use now, and most places use the Intuitive robot. But there are others, and some of them are focused on different things. Some are just used for orthopedics and so forth, like Mazor. And others are really trying to come up with alternate ways of doing robotic surgery and changing that. The two that are coming out that are considered to be the most has the most potential coming forward is one that's called Verb, and that's a combination between Google and Johnson & Johnson. Clearly two powerhouses, whether we're talking about the connectivity that Google can give, as well as Johnson & Johnson with their medical background. And then IBM and Medtronic is coming out with another robot as well that's going to be a few years behind. So there's a lot of exciting things on the horizon. Currently what we do now is fantastic. We're doing some things now where we're looking at, with Intuitive, where we can do image overlay. So what that means is we can take a CT scan or an MRI that shows a lesion somewhere, let's say in the kidney, for instance, and this is where it's first being done, so we're excited about using this in urology soon. Take that image, do a 3D reconstruction of the CT scan, and then overlay it in the abdomen when I'm actually operating to see where the tumor is, its relation to the blood vessels in the kidney. So if I'm going to cut out part of the kidney, I can figure out exactly where that is to save as much good kidney as possible, and also to clip individually blood vessels that are in that area so that there's less blood loss when we go to cut out that tumor. So these are things that are, absolutely amazing that we can do, and we're going to start doing these things with the current Intuitive robot, but these are on the horizon, and honestly, we don't even know what this is going to offer us coming forward. So some very exciting stuff.
I think that Google, the Verb, Johnson & Johnson and Google's partnership, they're even thinking of, now let's say we do a complicated case, well, we can call in our partners maybe to have some input, or maybe we have our partners have input before the surgery, but I think they're thinking of maybe being able to satellite someone in, whether it be across the country, internationally, maybe get another expert involved where they can see what you're doing and potentially help. So, fortunately, medicine is finally kind of coming on board with let's embrace technology and use it. Right.
So I'm going to turn it over to Dr. Kim, and go ahead.
So I'm curious, what kind of training does a surgeon go through to become proficient at operating one of these?
That's a great question.
Simulators, like
Yeah.
pilots?
There is. So that's a great question, because that is probably one of the most important parts about doing this, because we're doing something different, is knowing that your surgeon's well trained, but it's also that your team is well trained. Right? So one of the things that's very important is that when we operate as a team. It's not just the surgeon. And all of us need to be trained. So what we do is we train together. And I did training with this when I was a resident back in 2002, 2003, and all the way through, and been doing actual cases for over 12 years now. But there are there are ways to train where we do have simulations in the OR. So our current residents are trained side by side. There's literally two consoles right next to each other. It's kind of like when you drive a car and you have that steering wheel, and the instructor can take over right away. We have that type of training availability right now. There's also simulation labs where we go in, and it's not even on actual patients, but we're just simulating movement of things, cutting of tissue, cauterizing, movement of things through there, getting used to how the robot works and learning the fundamentals of it. So all of that is done now, and it's very, very safe and secure. And we make sure that all of our surgeons, before they actually go and are on the robot and actually operating on patients, have gone through all this simulation.
wake up and, because you're a great surgeon, that then all of a sudden you have access to the keys of, this amazing Porsche or whatnot. But, yeah, there's certain requirements for that.
I believe you have to have recertification if you don't have enough hours.
Right, that's right. And actually, the person, so I'm one of the new GYN oncologists here, but otherwise, I think, thanks so much. Marty Martino was the other GYN oncologist that has done this talk before with Dr. Bacala. And so I know that he is very involved in something called the Robotic Training Network, which provides that training. So it has a curriculum and certain guidelines as to you have to be a proficient bedside assistant. So meaning you have to know sort of the mechanics and how to troubleshoot the arms, and when you get into trouble, you also have to demonstrate on a computer that you can do simulation surgery before you are led on the console. And then just as Dr. Bacala described, now we have consoles that are an extra console for the learning, resident to train on, in addition to the surgeon who's, doing the primary case. And so it has become very fluid, and it has taken learning to a whole new level, which is pretty amazing. All right, let me see if, let's see. Oh, so let me go back. Oops. So what's great about this slide, I thought, and I can't take credit for most of these slides. I think both Dr. Bacala and Dr. Martino did an awesome job. So I'm just going to add my 2 cents. Is that now, of course, we're affiliated with Memorial Sloan Kettering. That's where I did my GYN oncology training. So it's pretty cool to see that relationships currently and ongoing. This is a graph showing you the impact of hysterectomy. And so on the bottom, it shows you the year. And on the y-axis, the up and down axis, it shows you the type of hysterectomy or the approach of removing the uterus and the cervix and things like that. And as you can see, early on in the 1990s, the purple dots are the open cases, right? So I would say for benign gynecologists, a lot of the open surgeries are sort of like across, kind of like a C-section scar. But for GYN oncologists, usually our surgeries tend to be up and down, like above the belly button, potentially up, up to the xiphoid and the ribs. So back in the 1990s, that was the, most common way to have a hysterectomy. Versus something like the Da Vinci robot obviously wasn't in existence back then, but laparoscopy, that blue line, was just hovering, and people were sort of experimenting and seeing what they could do, but not everyone was proficient in there. I mean, I'm thinking about residency. The skills that you need to operate on a robot compared to the skills that we learn for laparoscopic surgery are very different. Standing next to a surgeon and having small incisions and putting instruments in, we work on something like a fulcrum, meaning you have a long instrument, you want to move the instrument to the right, but actually your hand has to go to the left, because you're watching a screen. And so it takes a long time to learn compared to something like the Da Vinci robot now. And what you see really is, again, 2008, the Da Vinci robot, the cases where we perform hysterectomy are now starting to really take off, not only in a minimally invasive fashion, but this robotic approach, and the rates of open surgery. What we know from even randomized control trials that were done in GYN oncology is that even for endometrial cancer, which is a cancer of the lining inside the uterus, people used to think, well, you're going to miss something. If you do this robotically, you're just going to miss it, and you're not going to get the whole thing out correctly, and patients aren't going to do as well. And so there were randomized control trials that compared open surgery compared to laparoscopic surgery. So this is before the days of Da Vinci. And what that result showed actually was that the outcomes were equivalent. You could get the nodes that you wanted to get. You could get everything out that you wanted to get. And so that trial sort of revolutionized things. And now with the Da Vinci, we're able to translate a lot of those findings into, doing these cases in this small incision or minimally invasive fashion. So as the theme is less is more, back when I was training, we used to use blue dye initially. So let me go back. For endometrial cancer, so again, cancer of the uterus, for a while, GYN oncologists used to think that,
when I do surgery, I need to take out as many lymph nodes as possible. And so there would sort of be this competition. How many lymph nodes did you take out? And patients are going to do better, because the thought was, well, gosh, there might be hidden cancer in there. And so there were several trials done, both nationally and internationally, betting on the fact that if you take more nodes out, patients will survive better or survive longer. And actually, it's been more recently that those trial results have come back, and it actually showed that we did not help patients by taking out more lymph nodes. In fact, what happened back then, and I remember when I was training as a resident, really, we saw a lot of lymphedema, which is chronic swelling in the legs, because if you take out a lot of pelvic lymph nodes, there is just a lot of stasis. That lymphatic drainage from the legs is just sort of stays in the legs. So similar to, I think, breast cancer surgery in the past, when breast surgeons did a full lymph node dissection along the armpit area, I think a lot of breast cancer patients had lymphedema of their arm, where they're not allowed to have IVs drawn, IVs put there, or blood pressure cuffs put there. And it's a lifestyle change, in terms of just, I think cosmetically, women are uncomfortable with that. And then certainly, if you can imagine, the legs. So now with the results of these trials that have come out that have shown us, taking out 30, 40, 50 lymph nodes, if they're all negative and they don't contain cancer, that actually does not help someone who has endometrial cancer. So I was fortunate enough to be in a place where they were thinking about that at Memorial, and they were thinking, well, how can we be smarter about this? Is there a way we can figure out which lymph node might contain cancer? Like, how can we target that lymph node? And so again, taking from the world of breast cancer and melanoma, there are dyes that are injected near the tumor in those specialties, and there's something called sentinel lymph node mapping. Sentinel lymph node mapping. So what that means is, using that dye, you allow the normal body to drain that dye away, and as it drains away, it sort of enters into the lymphatic system. And what you can find is, if you go to the area that contains lymph nodes that drain that site, you will find a little dyed lymph node. So initially, we used to use blue dye. So, these are examples of 3 different blue dyes that we used to use in the past. And I remember Dr. Abu Rustam, who is now the chief of the GYN surgery department at Memorial, he really investigated this quite a bit using blue dye. And you can find the blue sentinel lymph node in the pelvis by injecting the cervix, the opening of the uterus, before you do the case. And there was a lot of debate that was going on in the GYN oncology community. Is this good enough? Are we missing things? And not everyone could sort of believe that we were finding these blue lymph nodes. And I think one of the reasons why is, and I'm sorry I didn't show you a picture of this, is, the vision spectrum, the color spectrum in terms of what we see. The problem is, you have to be pretty meticulous when you dissect out the pelvis and you open up, the side near where the blood vessels are and where the lymph nodes live. You have to pretty much not stain it with blood, because once you stain the area with blood, you can't really see the blue lymph node. Or a lot of times, most of the time, these lymph nodes are actually covered in fat. So you can't actually see the blue through that fat. And so for a while, this was sort of struggling to kind of pick up in terms of the world of GYN cancers. Like, is this doable? And what has been awesome is that with the Da Vinci, there's now an ability, this Firefly camera that picks up this indocyanine green dye. It picks up this green dye, and just with a little flick of the finger as you're operating, instead of seeing the regular color wave, you actually get everything else grayed out, and you can pick up this dye inside the abdomen, inside the pelvis. So I have another picture here. So again, I used to be a teacher back in the day before I went into medicine, so excuse my rambling, but just to give everyone sort of a format as to what I'm talking about, the organs I work on are down here in the pelvis. So here's a picture of the uterus, and the opening of the uterus is called the cervix, and the uterus is attached to 2 fallopian tubes and 2 ovaries. This is a picture of the vagina going up to the cervix. So again, the patient is asleep. We sterilely prepare everything. We inject this ICG dye here into the cervix. We go scrub, come back, We put the ports, make the incisions, put the instruments in, and by the time we look, this dye has traveled through the lymphatic system, and it will light up lymph nodes green. And the idea is that the first lymph node that it lights up green, the first or second, those are the most important lymph nodes to take out, because if cancer is going to spread from the uterus through the lymphatic channel, then most likely it'll hit that lymph node. And we know from studies that have been done that it is at least 3 times as likely to have a positive sentinel lymph node than just a random lymph node, that there actually is some order to drainage. So here, let's see if all right. I edited this video, so let's see. So here, we're looking inside the pelvis. The uterus is, I believe, up here. And so we're already in that space that we normally dissect. Oh, wait. Again. Try it again. There we go. So again, that's the regular camera. And then with the flick of a switch, you can see this dye. And it traces the lymphatic channel, which is that line going to this lymph node. You see how it's covered in fat? So I'm telling you, in the past, we would just take out big globs of fat, assuming that lymph nodes were in there. Anatomically, we knew what spaces to be in. But now we can really direct what we dissect. And so instead of taking out all these unnecessary benign lymph nodes that are good for the drainage of our legs, we can really target what important lymph nodes to take out. And these are the sentinel lymph nodes. So there's a whole, there's a whole algorithm. There's been a lot of studies done. And sort of part of my research when I was at Memorial was on this too. And so I'm happy to report that now performing sentinel lymph node mapping and biopsy is part of national guidelines for endometrial cancer and cervical cancer. So you don't have to remove every single lymph node. There you go. It's pretty cool, right? Yeah. So I think this slide probably refers to what Dr. Bacala was talking about in terms of the potential for this Da Vinci robotic surgery in terms of identifying a small lung lesion. This screen, again, just highlights, the top cancers, both in women and in men. And so, unfortunately, cancer is not something that is going away yet. We're all striving for that. But if there's a way that we can both make sure we treat the tumor appropriately and not compromise that outcome, but do it in a way where patients recover faster, they're on their feet faster, they feel better faster, I think that's sort of the way to go. This, again, we're just screening recommendations for breast, cervical, colorectal, and lung cancer. I'm not going to sit here and read all of this, but happy to answer questions. And this is in reference to the Robotic Training Network. So, I have to give Dr. Martino a lot of credit. I think he and other GYN oncologists really worked hard to establish this training curriculum that Lehigh Valley for sure is a part of, and a lot of other universities and academic centers have also are participating in. So now with a certain number of cases that they're able to do as a resident, plus additional cases and tests, they're able to become more quickly certified in the Da Vinci robot. Any questions?
Where does the name Da Vinci come from? Is that a brand, or where did that name come from?
I think, yeah. Do you have a...
That was just the name I think Intuitive gave it because it was, considered to be a form of artwork that they thought, so they that was their looking at.
I mean, when you think robot, I think Judy Jetson, C-3PO, but I imagine if you tell a patient you're going to be operated on by Judy Jetson, no, it wasn't Judy Jetson. What was that robot? The little Rosie. Right. I don't think Rosie was quite as inspiring, Any other questions we can answer for you? Yeah.
When you do surgery on patients, what is a good candidate? Which patient is a good candidate versus another?
Great question. I think for me, in terms of the GYN oncology specialty, the ability to operate on patients who are, let's say, who have more medical problems or who are heavier and bigger has really expanded with this Da Vinci surgery. In the past, I think we really used to worry about, let me take that back. Not used to, but let's say, for example, in patients who are very overweight or obese, it would be very difficult for them to recover from an up and down incision. Oftentimes they have diabetes, they have other medical conditions, and they're then in the hospital at least three days, maybe up to 5 days. It really depends. And then many times they might come back with a wound infection, or they then have to have a visiting nurse change, their dressing because their wound unfortunately has opened up. With this Da Vinci robotic surgery, we're talking about, small 8-millimeter incisions that we're able to put instruments in. The organs that we need to remove can be detached from all those important structures. And for me, I have a natural orifice, the vagina, where most things can just be pulled out of. So I don't even have to create a new hole. We're finding, I just operated on someone who was over 400 pounds. It's not an easy surgery, but she was out of the hospital she stayed that night just because she needed to breathe off the anesthesia, but she was able to go home the next day and is doing great. So it's really helped us. I mean, do you have anything else?
I think to add to what you said, I think that what the really unique thing is that we used to think, well, because this is new technology, we really only want to cherry pick those patients who we think are going to do well. That in its infancy, that was sort of what we did. Now what we're finding is the more complex patient, they're actually better off with something like this, just as Dr. Kim said, because we can, we're more comfortable with it, we understand what we can do with it, and we can actually do a better operation, even if they're more complex, the patient themselves, or even the tumor being more complex. We can do some really great things here and get into spaces that we normally couldn't do open. So it's actually expanded the number of people that we can treat. So it's
and what's
totally
interesting, sometimes we had for a while maybe some residency program directors or physicians who were very involved in resident training say, oh, well, with this robot, it really takes away from resident education. And I think that it actually doesn't. I think it helps in terms of minimally invasive surgery and open surgery, the anatomy that you see, how close you can be, the dissection you can do. They really go hand in hand. And it's a matter of just sort of helping the residents understand that because, we're not really able to dissect cadavers anymore. Once you're done your anatomy class and whatnot, we're helping and operating on real people. But the high def screen is kind of like the difference if you have cable between your standard screen and then when you switch over to whatever number, that 2000, you definitely want to watch it in HD, right? So it's similar to that. Yeah. Anything else we can answer? Yes.
I have a quick question. In terms of fatigue, with long, complex surgeries, do you find that this has helped because, A, the machine does not get tired, but do you find standing in one spot for long periods of time you need to take a rest? I'd be curious what it's like.
I think the Da Vinci robot has really extended people's careers. I think a lot of GYN oncologists who may be sort of in the age of retiring have been able to extend their careers and their knowledge and their skills because they're able to sit down. I don't know if you remember the screen a couple slides ago that Dr. Bacala showed. The robot holds those instruments. We are in 100% control of all the instruments. So we're the ones doing the surgery. The robot holds the instruments for us. So yes, I think that there's less neck and upper back fatigue. I'm not standing there next to the patient, moving my arms in these weird ways and using my legs, trying to look at a monitor. And the fact that I can use more than two hands. I mean, I think of it like driving a stick shift car. Normally for laparoscopic surgery, all I have are two hands, and then I have to rely on my assistant to use their two hands. So we can only hold about 4 instruments, right? So someone's got the camera, and then someone's got an instrument, and the other person may have 2 instruments. That's it. But with this Da Vinci robot, we're able to put the instruments in, sit down at a console. I have 2 hands, but I also have 2 feet. And we can sort of move between one instrument and another instrument, use our feet, and the pedals. So it's pretty amazing. It's like driving a stick in a sense.
I would agree.
Yeah. Yeah. So it definitely helps the fatigue. The robot doesn't get tired, thankfully.
Any other questions? Thank you both, and I really do. It really is fascinating where technology is taking us, and where, I mean, we look at the graph that Dr. Bacala showed us, where we've come in the last 10 or 20 years, where we're going to be 10 years and 20 years from now is fascinating. At this time, I would invite Elizabeth Wise, who is our president here at Lehigh Valley Hospital Pocono, and she can give us an overview.
Thank you. Good afternoon. Thank you, everybody, for giving up your time. I hate to say this, but happy fall, right? It's like 90 degrees outside and humid, so it feels a little odd being able to say that. I have a couple updates that I'd like to share with you, but also, more importantly, would like to hear from you. If there's things you're hearing in the community, questions that you have, things that I don't address in the topics that I want to share with you today, please feel free to bring them up. This is really, you know, when I initially started this, I said my role is to really share with you the good, the bad, and the ugly, and to be completely transparent with you. So a couple updates I want to share with you. One is that our hospice house has reopened. So yay. Mr. Weiler, thank you for all your support related to that. We reopened on Tuesday and transitioned the service from the hospital back to the house. We did that after regulatory approval from the Department of Health. So we are accepting patients. I will also want to give a shout out to our community group chaired by Mark Primrose, who is working with our community to raise philanthropic funds to help continue the capital, you know, that was required to reopen it, but also the ongoing operations. And our goal really is to coordinate that program on the home hospice as well as the hospice side if you need really inpatient care, so that we grow the program to be able to provide that service to the community. The second thing I want to mention is you got an email, or you might have seen information in the Pocono Record about a letter of intent that was signed between Lehigh Valley Health Network and Coordinated Health. Did everybody see that? We're trying to make sure that you get the information and that you're in the know as it relates to the community. So honestly, I can't share with you anything more than what was in the paper, right? We are waiting for regulatory approvals. We're required to go through that, particularly with the FTC and a couple other regulatory approvals. We anticipate that that will take 30 to 60 days. And then pending that, if it does get approved, then Coordinated Health would become a subsidiary under Lehigh Valley Health Network. So I'm getting asked questions, particularly from some of our doctors. You know, what does this mean? What does this look like? And I can only tell you what I told them. I don't know, you know, and that's sometimes very painful for me to say because I'm usually, you know, in the know, but don't really have a lot of answers yet. There are still a lot of unknowns. I want to mention Pocono West. We are still moving ahead with that. I mentioned last time that we acquired the land in Tannersville. We have drawings, as well as we are now working with the Pennsylvania Department of Health on the drawings and the approval process prior to the building. We know that we have to do some clearing of the land. We can't take down all the trees, and, you know, obviously it's the Poconos and there's a lot of, you know, we want to have trees and greenery. But, you know, fingers crossed, we would be starting that land clearing in the spring of 2020. And it takes about 12 to 14 months to build the building. So, but that is always depending upon regulatory approval, again, from the Department of Health. And also we have to go to the township to get certain types of approval. But we are still moving ahead with that project. Epic. That is an electronic health record that in October of 2018, we went live on the physician practices. October 1, what is it? Is that next Tuesday? We will turn it on in the hospital. And so Pocono, Schuylkill, and Hazleton will all go live with Epic, which is the electronic health record. Following that, in a couple months, our home care and hospice department will go up on Epic. So what does that mean to you? Like, what does that mean for you as our patients? One, if you use an LVPG Pocono provider, Lehigh Valley Physician Group provider, you have access now to your portal, right, where you have all the information about your electronic health record, your lab results, your radiology results. But if you came into the hospital right now, we use a different electronic health record, and they have some interface, but not complete. This will be one continuous record for you. And so even about 65% of the hospitals across the United States use Epic. If you went to another state and got ill, you could, and that hospital had Epic, they could pull up your record. So if you allow it, you have to give permission. So always permission. You have control about who you give access to your information. But that's the beauty, that it's an integrated, seamless record. So I'm excited, to go live with it. We've been preparing for this for over a year. We have a lot of colleagues coming up from the Valley. They went live with Epic maybe about 3 or 4 years ago. So they're going to do elbow-to-elbow support for us. And it usually takes a couple weeks to get up and running. But again, looking forward to the benefits for our patients, that will have access to information and that it will be integrated across wherever you go in the network. And then the last thing I just want to mention is we rolled out a new internet site that makes it much easier for you to navigate through finding a doctor, making an appointment, and it's less clicks than what we had before, and it really highlights the things that are important to you. You want to know about your disease state if you have a disease. You want to know who can I go see and how can I get to that provider. So I encourage you to, if you like to use the internet. If you don't, you can still phone our access center. For some of you that might not be as tech savvy as I am not, so I usually, call the access center, but certainly you have a number of different options. And then the other thing we rolled out that you might have seen across a lot of our billboards and commercials is our new brand, which is really Your Health Deserves a Partner. And we transitioned from a passion for better medicine, which was really about us internally, to now what you need in a healthcare provider, which is really a partner. And that partner can look different depending on what you need, but you may have seen our brand campaign, and we really take that very seriously, that all of our colleagues are thinking about what it looks like to be a partner, not only for you as the patient, but also for each other, right, as colleagues working together as part of a team. I'm going to stop there, because I really want to hear from you if there's questions that you have about anything I covered or anything I didn't talk about that's on your mind. Yes?
How extensive will the services be in Pocono West? Will that duplicate what's here, or will it be more a clinic type of operation?
Yeah, so the question is, how extensive will the services be in Pocono West? Will it mirror the services we have here? And the answer is no. We really want to try not to, we have to duplicate some services, right? I have to have a lab in the hospital. I have to have diagnostic imaging equipment. But I don't have to do cardiac surgery there. I have to take care of a patient who has a heart attack if they come in, right? Because that's part of the ER. But I'm not going to do cardiac surgery. We're very thoughtful about what services should be in one location, because you have the team there, you have the surgeons, versus duplicating the services. So no, the plan is not to do mother-baby services over there, or surgeries will not be done there. So it's really more of, inpatient care, mostly around medical diagnosis, and obviously we'll have emergency room and then ancillary services.
Just a follow-up question.
Sure.
In view of the fact that we have now St. Luke's in Monroe County, is there an adequate demand for these additional services?
So the question is, now that we have, and I'm not going to mention our competitor, I'll call them Agent X, Brand X, okay. Thou shall not be named. But is there a demand for it? Do we have enough beds? So before even St. Luke's entered the market, we had enough beds. What we have to do now is create what people want, which is access, right? Easy access, right? So I want to see a provider when I want to see a provider. And sometimes I could wait a week or 2 weeks, or I need to see them today. So what we need in Monroe County is access points so that people can access services. Now, some of that is because I just mentioned, our infrastructure, right? When we've done studies at Pocono and have asked how many miles somebody wants to drive before they can get to a doctor, it's 10 miles. Because we don't always have the road infrastructure, or people don't want to get on 80 because they're nervous and there's a lot of trucks and things like that. So what we really want to do, and that's why we brought Dr. Kim here, right, is hire providers, open up access for people so that they can get the access and to care. And that's really the purpose behind Pocono West. Yes, Sharon.
Thank you. The follow-up to that would be, when are we going north up to 09? Because there's nothing between here and Scranton, Milford. I'm not sure. There may be something there, but not much.
So I have 2 words, stay tuned.
Okay.
Okay, stay tuned. I don't think we haven't thought of that. So, and I get asked that question a lot because of the same reasons, right? You got to travel down 209. The weather's bad, and I can't get there. And
Emergency response is forever.
Right.
Because of the location, the topography.
Yeah, right, because of a number of different reasons. So, yeah, please stay tuned. Yes.
Elizabeth, just input. We're talking about all of the technologies that we have. This is very low tech, but I went in for a chest x-ray a few weeks back, and I never had anybody hand me a thank you for coming in and allowing them to render services. So, and hand sign. Yeah. And I thought that was pretty low tech, but it made an impact because no one's ever handed, maybe none of you have ever received one. But I thought it was a nice thing to do at the diagnostic $400 billion.
Yeah, thank you very much for recognizing that. You have options, right? You have options in the community. And so I thank people for choosing us because you have the option to not choose us, right? We have competition in the area. And so we want to go out of our way to recognize that and to thank people when you do decide to choose Lehigh Valley Hospital Pocono. So thank you very much. And you're right, it's low tech, right? Yeah, doesn't cost a lot. It recognizes people for coming in.
Articulated as well as handing me, card. He articulated it, which really drove the point home.
Okay, so instead of just handing you the card, they also are verbalized the same thing. Okay, thank you. I appreciate that.
Reinforce the program.
Okay, great. Thank you.
Last question here.
Will we expand mental health care, and particularly in the pediatric field?
So a couple things. The expansion of mental health services, we're really focused on a couple different things. One is depression screening. So our Lehigh Valley Physician Group physicians have started an initiative, and it's one of our goals this year, is to increase depression screening, and then obviously connection to services, referrals to services, depending on the score and where it comes out to be. We're also here at Pocono part of the Monroe 2030, the healthcare component, which is looking at destigmatization as it relates to opioid use. Denise, I'm looking at you. So if you want to add to this, just let me know. I don't want to steal your thunder because you're the chair of that group. So we're really taking a look at, again, if somebody does have a substance abuse issue, that you're able to approach them, work with them. We had a simulation exercise here and education that we want to provide to our providers. So there is less of that destigmatization. Related to the pediatric piece, I can tell you that I was approached by one of our local government officials who is very passionate about that and would like to take a look at how they can partner with us as well as the schools, because there's a lot of concerns that have been identified with the schools. And we met with our chair of our behavioral health department. His name is Dr. Norris, who we can talk about potentially looking at some type of potential telepsych that we can beam into the school. We have a lot of telehealth programs here at Lehigh Valley Health Network, and one of the things that we're offering now is telepsych, so that somebody's at the end of a camera, somebody's with them, like usually a social worker or a crisis worker, and the psychiatrist can beam in and speak to the patient, get some additional information, and be able to provide a treatment plan. So just started those discussions initially to see if there's any type of grant funding or other monies that we can use to try to seed the program. Thank you. Thank you very much. I really appreciate you coming and for the thoughtful questions.
Okay. Thank you, Elizabeth. And at this time, we're going to adjourn the meeting. I wanted to, before you all go, encourage you, if you enjoyed what you heard today, you liked the presentation from our thoughtful physicians, please bring a friend with you or reach out to us and tell us that you have someone in the community, a colleague, a friend, that you think would make a valuable part of our Board of Associates. We always encourage you to bring those folks along. I want to thank Drs. Bacala and Dr. Kim. Another round of applause for them. Thank you, Elizabeth. Thank you, Erin, for coming up from Lehigh Valley Cedar Crest. And one last thing I want to say, if you do go to lvhn.org, there is a gentleman sitting in the back of the room here who will greet you with a wonderful smile. He is... Thank you all. Meeting is adjourned, and we'll see you in November.